Hello, I'm William Zoghbi, Chair of Cardiology at Houston Methodist here. It's a pleasure to welcome you to our cardiology grand rounds. This is September, and it heralds the start of our academic year. It is a pleasure to have you and host you every week on Thursday. And the beauty of it is also you can watch it live as well as on our YouTube video channel, DeBakey Education, where you can join more than 60,000 people who have been following us for our educational offerings. We'd like these grand rounds to be interactive. So, you could chat with us or send us questions either on the web when you go to paulev.com and enter DeBakey, or join us by text, texting DeBakey to 37607 and text a new message. I want to also thank Dr. Valeria Duarte, who is the director of our Grand Rounds, because for this year we have an amazing array of topics and experts in the fields, in various fields, from interventional to structural heart, prevention, imaging, heart failure, and electrophysiology. So we really would love for you to interact with us throughout this year. And hopefully, maybe in 2022, we could start hosting these in a hybrid mode, physically as well as on the web, just like you're seeing it today. So without further ado, let's start about the topic of today. And in thinking about the topic of what would I share with you at the beginning of this academic year, I thought of aortic stenosis because, one, it is dear to my heart. This is where I started my academic investigation and careers on aortic stenosis. But I think it is amazing that this field of a stenotic valve has evolved so much over the years. And we have new insights nowadays from truly a new world order of new diagnostics beyond certainly echocardiography and any electrocardiogram. And therapeutics, I think with the advent of TAVR, we understand even more about the pathophysiology and the remodeling of the heart in response to relieving the pressure load on this ventricle. So to get us focused, I think this is a reminder of what the pathology of an aortic valve would be. On the right upper here is a bicuspid aortic valve with some calcifications. This is a rheumatic etiology of an aortic stenosis, where you could see the commissural fusion and much less calcification. So when we talk about calcifications, you have to kind of think of also the etiology of it. Yes, we see quite a bit of the degenerative calcific type, but in different parts of the world you may see more of these. And this is the most frequent abnormality in aortic stenosis, which is the calcific aortic stenosis, where calcifications occur not necessarily only at the tips of the leaflet, but also in the cusps themselves. And this is where we have to kind of think of caution when we image this valve and try to infer stenosis etiology. There is a global burden, certainly, of aortic stenosis, and this is a very recent publication spanning 30 years of the trends in either prevalence or death, and you could see that. And these are by socio-demographic index quantiles, so you can think of different countries in the world. And you could see that the increased prevalence in high SDI versus even low SDI, in addition to the burden also of death. So we have to manage this disease in so many ways, and the prevalence is increased not only because of recognition, probably also we're not managing as much the risk factors that would contribute to the presence as well as the progression of aortic stenosis. I think we're all familiar with the stages of aortic stenosis, because with increasing severity, and it's a progressive disease, slow disease, starts burdening the ventricle itself. So ventricular function is altered. There is remodeling of the ventricle itself. And it goes from an asymptomatic to a symptomatic status, where you have severe disease with influence also on flow. So you could have a low flow, low gradient aortic stenosis, which complicates things. Now, this is a a historical, if you will, graph depiction from Doctors Brownwald and Ross. And this was amazing, actually, from a vision point of view, because this is more than 50 years ago, depicting the natural history of aortic stenosis with a latent period with increasing obstruction and load. And then once symptoms arise, the prognosis is certainly made much worse, and depending if you had angina, syncope, or heart failure. And you know, nowadays probably we would shift this curve a little further down, because at that time it was the longevity of people was less, and in addition we had much more of a bicuspid aortic valve. So nowadays most likely we are shifted this into the 70s and 80s, but still the natural history is similar. However, there are a few things that I think that we need to address and see whether we can understand this latent period, particularly towards the end of that latent period, where it conceivably could help us in managing patients better and decreasing the morbidity and mortality after an aortic valve replacement. So with that in mind, nowadays, over the past few years, there have been really a changing in the landscape of diagnostics. So we're much more beyond a 2D echocardiogram. We have strain in addition to the Doppler, but also CMR and CT. Very powerful diagnostic and helping us in therapeutics, in addition to some biomarkers. But also the therapeutics point of view is with lesser invasive procedures to replace this valve, we're able to intervene earlier conceivably and with less risk on these patients. And I think it has allowed us also to understand better more about the aortic stenosis. A tremendous increase in publications of aortic stenosis, so I'm not thinking of reviewing all these, but it is an amazing load of information, particularly over the past few years. And I recall in 2000 when I chaired the scientific sessions for the ACC, aortic stenosis was not the most exciting topic for people to go to, but nowadays structural heart and aortic stenosis certainly at the forefront. We know there are several factors that affect progression of aortic stenosis. This is not one I'm going to address today. Age, hypertension, diabetes, hypercholesterolemia, certainly renal disease, any inflammation, systemic or even of the valve itself, valve calcifications, and even genetic mutations can affect the progression of aortic stenosis. But what I would like to do today is to review with you and address few things. One is defining the severity of AS and its challenges, how to address low flow situations, because I've noticed that from practices of every day that this is still a bit challenging for the clinician. Insights from advanced imaging, CT and CMR, recent prognostic indicators and modifiers that conceivably could change our approach down the line to aortic stenosis, and future research to optimize our interventions. So from an echocardiography point of view, which is really the first line of diagnostics that we do nowadays, we evaluate the aortic valve and its structure, the adaptation to the pressure overload by LV size and hypertrophy, LV function, certainly systolic as well as diastolic, and look at other etiologies of murmur that could be mimickers in this disease. And I think this is very helpful for all of us to keep that in mind, because this is where the first initial evaluation of such patients, in addition to following up such patients from a progression of the disease itself. And this nice depiction from Dr. Liv Hatley, who's really the founder and mother of Doppler echocardiography, you could see what happens to the progression of aortic stenosis, increasing velocity through the valve, in addition to a prolonged ejection time, in addition to a late peaking of the velocity itself, which is reminiscent of the pulses tardus and parvus that hopefully some of our clinicians still can use at the bedside, but this is very nicely depicted on Doppler. Now, how do we assess that? Obviously, in a stenosis, you're going to have increased velocity through the aortic valve itself. However, it is flow dependent. right? So if you have a high flow situation, you're going to have a high gradient for the same degree of stenosis. But more challenging for aortic stenosis is a low flow situation where the gradients would be low, yet the valve area is small. And this goes back to our first publication on this. Actually, we presented this when I was a fellow in 1985 at the ACC. Using completely non-invasive method to take a look at not only the gradients but also valve area, which is very important, particularly in low flow situations. And deriving a valve area would require assessment of a cross-sectional area in the LV outflow tract to determine your stroke volume in addition to the gradient, and then solve the equation for the continuity equation. For our fellows who may not go back enough in the literature, this is a comparison with the Gorlin equation between a valve area by Doppler, and from us here, Houston Methodist, as well as Mayo Clinic, with his Dr. J.O. Very similar graphs telling us few things: that if the valve gets very tight, the correlation is very good. If it is not very tight, the correlation is not as good, because the Gorlin equation actually does not work well in low flow situations as well as in milder stenosis. So keep that in mind when you at times look at relations between invasive catheterization measurements of valve area versus Doppler. Now, our Doppler assessment of aortic stenosis uses few criteria. One, maximal velocity and gradient of the Doppler, mean gradient, valve area using the continuity equation, particularly in low flow, low gradient situations. And we look qualitatively at the contour of the jet, how rounded it is, telling us, similar to what I showed you earlier, what's the acceleration time and the ejection time, because these get worse as the severity of aortic stenosis get worse. These are qualitative yet important criteria to look at the severity of obstruction. Today is not a talk about echo Doppler only, but I know that these are very important for us to review because many clinicians actually use these in their offices. And there are a few nuances. One is that you have to measure the largest diameter, otherwise you're going to underestimate the cross-sectional area of flow. So use it at the at the annulus itself of the aortic valve. This is how we validated it very early on. And don't use an average, use the maximal one, because the most that you could do is underestimate this diameter. Two is, if you have calcifications in the LV outflow tract, you will underestimate the cross-sectional area of flow, because this is not all around the annulus. So you may have to use flow from another site, or from the ventricle itself, or just report a gradient if you're uncomfortable with that, so that people can infer what the severity of the aortic stenosis in that particular situation. Now, another modality that is very helpful in your day-to-day practice is CMR and aortic stenosis. Not the first line, but it certainly can be very helpful in looking at the aortic valve morphology, anatomic valve area, and you could see here a bicuspid aortic valve versus the normal valve versus the tricuspid aortic stenosis. It can measure the velocity, and you can look certainly at volumes and mass and function, and importantly, myocardial fibrosis, as well as assessment of the aorta, particularly in bicuspid aortic stenosis. Few thoughts regarding that, because at times you may get some of these measurements. Anatomic area, if you measure the anatomic area, usually larger, be it CMR or on CT, then an effective orifice area. And remember also, the Gorlin equation is an effective orifice area, not a geometric area. So they will be larger. And I think most of the data that we use from a prognostic point of view is using the effective orifice area. Yes, you could use that with CMR, but there could be some problems. So I think if the echocardiogram is not very diagnostic or problematic, and you want to use a non-invasive way, certainly you could use CMR. At times there may be underestimation of the velocities because the imaging plane was not perpendicular, or if you have a signal loss in turbulent jet. And importantly also, there is a lower temporal resolution compared to Doppler echocardiography, if you will. But certainly, if you have a jet velocity that is very high, you know that you're dealing with severe aortic stenosis. These are the criteria by most guidelines, be it ACC/AHA, ESC, or American Society of Echocardiography. And I'm going to concentrate on severe, greater than 4 meters per second, greater than mean gradient greater than 40, and a valve area less than 1 centimeter squared. Remember, these are usually in low or high, in normal or high flow conditions. Flow is, defined, but I think certainly it is a moving target. It's not necessarily only 35 ml per meter squared, but you have to kind of keep that in mind as to what kind of low flow situation you're dealing with, or normal flow. But part of the issue comes in many investigations and publications is that these go together, but this one is a little different diagnostic predictive accuracy for it. Is much more sensitive as opposed to the other ones being more specific. And these were actually very nicely depicted from a recent publication a few years ago, actually, from Dr. Minners, looking at the relation of pressure gradient with valve area. And probably the most cutoff, the best cutoff is about 0.8 centimeters squared. So if you're closer to 0.8 or below, you're dealing certainly with severe aortic stenosis. And the other is the cutoff of 1 centimeter squared is more sensitive and less specific, but if you want them to match, they will be closer there. Part of the reason to keep the 1 centimeter squared is, yes, you have a more sensitive area, so you have to kind of put it together with the gradients and the velocities. 2 is because of errors at times that you may get in measurement of valve area. You don't want to underestimate or the severity of aortic stenosis, but keep those in mind, because at times it may give you a little discordant information. And don't stick to the actual cutoff per se. Think about it collectively from a stroke volume, mean gradient, velocity, as well as valve area. A case, an example, patient of mine here, stroke volume of 70 ml, mean gradient of 23, yet valve area is 0.95. Is this severe aortic stenosis? Not by gradients, particularly the stroke volume is good. And also the characteristics of the jet itself. So yes, it is less than 1 centimeter squared, and usually it behaves as a moderate aortic stenosis. And you follow such patients over time. They asymptomatic, all the way through after 4 years. And this is the natural history of progression of calcific aortic stenosis. As the gradient is much higher now, stroke volume is still good, valve area certainly much tighter, and this is time to intervene. The earliest data, and actually wonderful prospective data, was from Dr. Otto, Catherine Otto, looking at velocity itself. And also in parentheses, the most reproducible is the velocity as well as gradients themselves, because there's only one measure as opposed to a derivation of an aortic valve area where the error could be 10–15% or so. So velocity less than 3, usually a nice milder course. A moderate between 3 and 4, greater than 4. Again, most of the time this would be in a setting of normal flow. If you have a low gradient similar to the patient I showed you, but a severe quote-unquote aortic stenosis less than 1 centimeter squared, it actually behaves like moderate aortic stenosis. But you need to follow the patients well because of progression of the disease. The entity that gives the most problems, if you will, and you need to do more to understand it and evaluate it, is the low flow situation. Low flow, low gradient, severe aortic stenosis. This is the definition in a way: a lower stroke volume index, a mean gradient less than 40, but a valve area less than 1 centimeter squared. And these are the situations here: low stroke volume because of depressed function, low stroke volume because of a small ventricle and normal ejection fraction. So it's basically a small ventricle that is still ejecting well. Or you may have errors in calculation, just like I mentioned you, and this is usually your first line echocardiogram. Is the measurement good? Where are the signals? How good or how bad these various measurements are. And I think this is very important to kind of put it together. Now, if you have a low flow in a low EF situation, Let's take this example here. Is this severe aortic stenosis? I have a stroke volume of 45, a mean gradient of 30, and a valve area of 0.7. Certainly of concern, but the stroke volume is very low. And the recommendations in this situation, I think these are also endorsed by all the guidelines, is to do a maneuver that will increase flow so that you can reassess what the gradients are, but also importantly what happened to the aortic valve area. Because as we know, normally as well as even in stenotic valves, the valve area itself can be flow dependent, much less than gradients, but certainly can be flow dependent. So you use dobutamine with echocardiography up to 20 mics per kilo. And these are the different responses that you may get. If I increase my stroke volume and ejection fraction and the gradient increases, but valve area doesn't change, this is severe aortic stenosis. If the flow increases and the valve area increases, AS is not severe or pseudo-severe, if you will. This is the most challenging situation. If I have no further contractile reserve and my stroke volume does not increase, is this severe cardiomyopathy or is this severe aortic stenosis? Let's take a case here. 87-year-old gentleman with coronary disease, aortic stenosis, heart failure, symptoms, echo Doppler gradient mean of 30, valve area of 0.8. Is this severe aortic stenosis? Is this what's causing the depression or at least contributing to the depression and ventricular function? So we do a dobutamine echocardiogram, and you could see how bad the ventricle is. There is some improvement in ventricular function. This is the baseline, increasing to up to 20 mics per kilo or so. You could see that some improvement in ejection fraction to high 30s. And this is baseline versus peak. At baseline, the stroke volume was 45. It increased to 66. Mean gradient, however, increased from 30 to 43, and the valve area stayed very in the tight range, about 0.8 or so. So this is severe aortic stenosis in a low flow, low gradient situation. Contrast the previous case to this case of a baseline of stroke volume of 44, increased to 76 with dobutamine, valve area from 0.9 to 1.4. And the gradient really didn't increase that much. Always gradient will increase some because the ejection time decreases a bit, but certainly this is pseudo-severe aortic stenosis in the milder range. Now, what if no or minimal change in stroke volume occurs with dobutamine? I mean, you're really struck because you're not able to increase, stroke volume through it. And this is, I think, where newer modalities can come to the rescue and help. And this is assessing aortic valve calcifications using CAT scan to assess the severity of aortic stenosis. This is from an earlier investigation. Senior author was Dr. Maseka Zaytoun. And you could see the relationship of aortic valve calcifications. These are units, Agustin units versus aortic valve area. Yes, there is a good relationship, but also notice that there is certainly a spread, but there is a relationship that conceivably could help us. From a more recent investigation by Dr. Marie Clavel from Canada, who has really been amazingly productive in this field and has shed quite a bit of light, she and her group in Montreal. This is the distribution by sex and groups of severity of aortic stenosis. I'm not going to go through each one of them, but this is the milder group, and this is the most severe group. And you could see that in men as well as in women, there is an increase in calcifications that goes along with the severity. The calcifications in men are much higher for the same degree of aortic stenosis compared to women. So I think we have to keep that in mind and think about it when we have such a case. And these are the latest recommendations, actually. Some of them are actually in the European Society of Cardiology most recent guidelines, if you will. This is the best cutoff for men and women. Agustin units greater than 2,000, greater than 1,200, and the best meaning a good balance between sensitivity and specificity. And I think in these situations, we'd like to be even more specific if possible. So keep those in mind, that for a high specific, greater than 95% or so specificity, a very high calcium score in these situations. It is measured in non-contrast ECG. This is an important one. Calcifications in the LV outflow tract, mitral annulus, and coronary arteries should be carefully excluded. Otherwise, you're going to increase that calcium score. Certainly most helpful in low flow, low gradient severe aortic stenosis who do not or cannot exhibit an increase in flow during the butamine or any other maneuver. You could exercise people if you want to, whichever way, but I think this is a much more controlled situation. So very helpful technology. And also it has prognostic indicators, obviously, since you're dealing with severity of aortic stenosis. So to close the chapter, if you will, on low flow, low EF, low gradient severe aortic stenosis, if we're dealing with such an entity, we need a low dose dobutamine stress echocardiogram. We don't start with a calcium score. And I think this is important because physiologically, that is also very helpful from a prognostic point of view. If the mean gradient increases significantly, you have true severe aortic stenosis. On the other side, if the gradient still is not in the severe range and valve area is greater than 1 centimeter squared, it is pseudo-severe. And if you have something in between, this is where you have to have a closer look and assessment on what is change in flow area and flow, the gradient. Is stroke volume still reduced? How close are you really? And these cutoffs are not so rigid. And I really think you need to take a look at all these, indices that we just talked about and put it together. Calcium score certainly for if you're stuck in this situation, and this is really very helpful, going forward to try to make your decision as to the severity of aortic stenosis. Another entity that also came about in these investigations was paradoxical low flow, low gradient aortic stenosis. And the word paradoxical reflects basically that I have a normal left ventricular function, normal ejection fraction, yet the situation is a low flow condition. And why? And I think you would think immediately that the ventricle should be small for whatever reason. And actually these are very nice reviews by Dr. Pibarot, Dumenil, and the group again from Canada, who had significant contributions to the field. These are the clinical situations that would produce such a reduced forward stroke volume. Most commonly is a small left ventricle with pronounced concentric remodeling. Yes, you have situations where you have mitral regurgitation and therefore the flow through the aortic valve is reduced, or you could have a right ventricular failure causing a unloading of the left ventricle itself, severe tricuspid regurgitation, impaired diastolic filling. This is an issue by itself. And I'll take the time here to say for atrial fibrillation, it is difficult to assess valve area. Gradients will change depending on the RR interval, but valve area, you really need to match the previous RR interval of your flow in the LV outflow tract versus the aortic valve. Either average many beats, which most of the time we don't do, but I think matching a preceding RR interval in these two situations will give you a much better assessment of the situation. So all these would lead to a low paradoxical, low flow, low gradient with normal ejection fraction. Let's take a case here. This is you could see how the aortic valve is not moving well, hypertrophied left ventricle. Don't be fooled by its size. If you actually measure the size, and even a linear measurement is less than 4 centimeters, so it's a small ventricle by itself. And look at the gradient. Stroke volume is 55 by pulse Doppler. Mean gradient is 23, yet the valve area is 0.7. And you take a look at this looks like a longer ejection time, a nice and rounded velocity, but the usual problem is you want to make sure that this number, the stroke volume estimate, is correct. And therefore you have to use beyond Doppler what your stroke volume is from the ventricle itself. So we try to corroborate that either qualitatively or quantitatively using 2D, and you could be 2D or 3D. And the ventricle at end diastole is small at 95, and your stroke volume is about 50, which is very close actually to the small number of 55. So it gives you comfort that you have internal check regarding the stroke volume, so you're not erroneously portraying a low flow situation and severity of aortic stenosis in a low gradient situation. So I would refer you to this editorial I did for Jack regarding this situation. It is truly trust but verify. You have to verify it. As a clinician, you may want to make sure that you understand that kind of situation and corroborate it, but certainly for the diagnostician, the imager, we have to do everything in our power to make sure that these numbers are correct, because they will influence clinical management, prognosis, and also ultimately the management by the clinician. Now, in the remainder of the talk, I'd like to share with you a few thoughts and data on modifiers, prognostic indicators that are emerging in aortic stenosis. And I think they have not yet made it to the guidelines, conceivably, not all of them. But I really think that they are an eye-opener and also modifiers of our assessment of aortic stenosis. From a prognosis point of view, according to flow and gradient, the worst kind of situation is a low flow, low gradient aortic stenosis, similar to the cases we just showed you. And the low flow, interesting as you will see, the low flow is almost independent of what the ejection fraction is. It sounds paradoxical at the beginning, but if you think about it, it may be real. Now, the better situation is a normal flow high gradient, meaning that if you relieve the high gradient, obviously, you're going to get to a better situation from a prognostic point of view. These are data from partners A and B according to flow and ejection fraction. And I think this is an eye-opener. Obviously, this pertains to the population enrolled in partner, which is calcific, older individuals, and everything else. But if you take a look at these data, this is low flow versus no flow, normal flow situation. 2-year death much higher in a low flow condition, which is in a way expected. The less expected, at least in my view, was the ejection fraction. In a low flow situation, be it a normal ejection fraction or a depressed ejection fraction, the prognosis is about the same in these trials. And it may tell you something that in this particular patient population, because the ventricle is so small, and it may be small because of other factors, either hypertension, frailty, comorbid conditions, and so many other things, that if you have a very small ventricle in an elderly, with aortic stenosis, it may not impart, such a good prognosis. The other thing is, this is according to type of intervention from that same cohort. Basically, if you have a normal flow situation, TAVR or SAVR or surgery, better prognosis than if you had a low flow situation. And it didn't matter really as much if you had a TAVR or a surgical intervention. Basically, a low flow condition, be it normal ejection fraction or a depressed ejection fraction, we don't know the spread of that data, is really doesn't pertain a good prognosis for patients. How about dobutamine stress echocardiography in a low flow situation? Better prognosis if you have an improvement in ejection fraction during dobutamine, if your valve area is greater than 1.2, if your 6-minute walk distance is larger than the other. So intuitive, if you still have flow reserve, if you have contractile reserve, usually you will do better. Certainly with interventions most of the time, but even medically, if you cannot intervene on these patients, they will do better. Now, as you know, we have also quantitative criteria, and quantitative methodology with myocardial strain. Global longitudinal strain is really a very powerful way of quantitating systolic function, also diastolic function, but certainly systolic function. We know in hypertrophic states, GLS would be reduced because of different deformation of the inner fibers of the myocardium. And so you would expect that GLS would be low, and also GLS will have a prognostic impact on patients even with hypertrophy from hypertension, you know, let alone probably aortic stenosis. So these are more recent data from using global longitudinal strain in asymptomatic severe individuals, and this is a conglomerate of 10 studies, more than 1,000 patients, that if your GLS is less than, let's say, 14.5 or so, just reduced. As you know, normal is about 17 or 18. Below 17 is definitely reduced in most laboratory data. And let's say if it is less than 15 or so, it impacts, you know, significant deterioration in prognosis. Talking about GLS, I think it's important to state that we've made more aware of cardiac amyloidosis in the patients with aortic stenosis. Certainly, if you don't have an aortic stenosis, cardiac amyloidosis, it's easier to suspect because you don't have a pressure load situation unless you're dealing with end-stage renal disease or severe hypertension. But I think it complicates the situation here if you have cardiac amyloidosis and aortic stenosis, because you would think that the aortic stenosis is the cause of the increase in LV mass in these individuals. Interestingly enough, that the contractility of the apex is preserved, and that's why you have this pattern on the global longitudinal strain with called the apical sparing or cherry on the top, a low voltage on the electrocardiogram that helps you suspect this. On a CMR, if you do a CMR, you see the late gadolinium enhancement, not in the only subendocardial area, but in different parts of the myocardium, including the right ventricle. And on a scan, a nuclear scan that emphasizes bone, pyrophosphate or the alike, that you will see quite a bit of an uptake in the myocardium itself. So we have to keep that in mind, because the prevalence of this is about 15 or so % of patients with aortic stenosis who may have it. This is a very nice review recently in JACC, and I'll highlight the amyloidosis red flags that we have to keep in mind if we see patients like this. Older individual at 65 years of age or older, more predominance, predilection for males. Carpal tunnel syndrome, very high. Actually, there's a recent scoring system that gives it almost 3 times the score of other findings. Low voltage despite LVH, pseudo-infarction pattern. Biomarkers, troponin much higher elevated. Transthoracic examination, we talked about hypertrophy, we talked about the apical sparing, and CMR, we talked about also the LGE and elevated ECV values. So I think you have to keep those in mind. Now, diastolic dysfunction, aortic stenosis, is very prevalent. Obviously, you have a hypertrophic state, you have pressure overload, and these are the different grades that you see. So we know we have impaired relaxation. The question is, what is the filling pattern like, and its implications regarding filling pressure? A slow relaxation pattern here, quite a bit of impaired relaxation, a pseudonormal or grade 2, and an impaired relaxation situation, and a grade 3, which is restrictive, very high filling pressures. You would think that these obviously may relate to symptoms, particularly during exertion, as opposed to the first one, but you know, symptoms can be present in different circumstances depending on physical activity and otherwise. And these are more recent data, actually, looking at diastolic dysfunction prevalence and relation to prognosis in the partner trials. Take a look at this dysfunction pattern, the slow relaxation pattern, is the most prevalent. However, you have about 40% of the time of these patients enrolled in these studies that may have either the grade 2 dysfunction and less frequently a grade 3 dysfunction in such patients. Now, after a TAVR procedure or an intervention procedure, these patterns, yes, changed, almost crisscrossed at times. Yes, there is a little bit more prevalence of the slow relaxation, normal filling pressure pattern, but many of these lasted actually even after relief of the pressure overload, which is of concern obviously because many of these patients will still be symptomatic. And indeed, it is very interesting looking at prognosis, death or rehospitalization, obviously for heart failure usually, is if you have this restrictive pattern, the incidence of death or rehospitalization is much higher than if you had a slow relaxation pattern indicative of decent filling pressures of the ventricle. Now, along the line of diastology, think about BNP, which actually made it to the guidelines. In moderate or severe aortic stenosis, the higher the BNP, this is 1 time, 2 times normal, 3 times normal, a worsening overall survival in such patients. This is all patients. This is asymptomatic with normal ejection fraction. Still the same pattern, certainly a better prognosis than what you had for all patients in an asymptomatic individual. But really the worst is 3 times here normal, a much worse prognosis overall survival point of view. And this is also of concern, is that if you had a high BNP to start with and you did an aortic valve replacement, still the prognostic implication for such an abnormal measurement is there even after aortic valve replacement. Now, recent data is interesting here because also it made it to the newer guidelines, meaning that traditionally you would think of aortic stenosis that no matter what the situation is, if you have an ejection fraction of about 40% or 50%, that after relief of the pressure overload with an intervention, either TAVR or SAVR, that the ejection fraction will improve and the prognosis would be good. Actually, recent data tells us that there is a continuum of ejection fraction and its implication to prognosis. Take a look on the left side here. These are patients stratified, so this is severe aortic stenosis, survival post-SAVR, severe aortic stenosis, irrespective of symptoms here. Take a look. Ejection fraction greater than 70%, 60 to 69, 50 to 59, and below 50. Now here, if you take even symptoms with that, the asymptomatic obviously has the best prognosis, but even a cutoff of 60%, below 60%, imparts a worse prognosis in such patients. So yes, ejection fraction may tell you that the ventricle is still functioning systolic-wise at a decent level. But as you will see also, there probably is some damage to this ventricle already from the chronic pressure load situation, conceivably telling us also about the worst prognosis in patients, even in the asymptomatic ones with a cutoff of about 60% or so. Well, with CMR, I think there is so much power nowadays to take a look into the ventricle itself, the muscle itself, not only looking at the degree of LV hypertrophy, but also look at the extracellular expansion with measurements of extracellular volume percentage, ECV, or replacement fibrosis, the uptake, the regional uptake by gadolinium, late gadolinium enhancement. And these are some nice, very recent investigations here on mapping for ECV, in addition to late gadolinium enhancement, a normal myocardium, extracellular expansion, where ECV is increased more than in the mid-20s or so, and an assessment of replacement fibrosis with LGE. I know the font is a bit too small for you to see that, but basically this is the various characteristics of these patients with aortic stenosis, about a sizable number, more than 200 patients, normal myocardium, extracellular expansion, and replacement fibrosis, looking at various characteristics: LV mass, troponin. This is diastolic function, and this is importantly survival here. And the worst survival is those patients who have significant replacement fibrosis. The best is normal myocardium, and in between, an increased and extracellular volume percentage. Now, after a replacement of the aortic valve, some improvement occurs, and this is CMR studies in almost 200 patients or so, that LV mass decreases, cell volume, the hypertrophy itself decreases, and therefore your matrix volume also decreases. And if you want a schematic a depiction of what really happens during aortic stenosis and after an aortic valve replacement, the worst that really happens is, or the no change, is in the replacement fibrosis. So you may have patients with replacement fibrosis that will maintain it. After aortic valve replacement and reduction of the pressure overload, cellular mass, the myocardium per se, decreases, as well as the diffuse fibrosis that occurs. Now, interestingly enough, if you keep that in mind, there will be a study, actually planned study, to take a look at these changes and conduct a study for aortic stenosis patients. This is also a very, very elegant study just this past month, actually, in JACC, looking at markers of myocardial damage, and this is a correct nomenclature here because they're looking at LGE and fibrosis itself, predicting mortality in patients with aortic stenosis. They looked almost 30 variables, clinical variables, echo variables, as well as CMR, and had a random survival forest model. And take a look at the ones that are garnered from the CMR. They looked at LGE as well as the extracellular volume, and the model was also age, peak velocity by Doppler, and all the others. And this is a nice depiction of all-cause death. It is nonlinear. And if you take a look at this here on the left side, this is percent ECV and LGE in patients with aortic stenosis. The worst prognosis are for those patients who have late gadolinium enhancement, basically a replacement fibrosis, as well as a very high ECV percentage. And if you take a look at their cumulative mortality, ECV cutoff of about 27%, their adjusted mortality increases. So therefore, the remodeling of the ventricle itself, not only hypertrophy, but also what happens to a replacement fibrosis, the extracellular volume that we may have, will impact prognosis in patients with aortic stenosis. One publication, which also took a lot of attention, and actually many other studies have emulated in a way, it has a good message, but also you have to be a little cautious about it. This is staging classification of aortic stenosis based on the extent of cardiac damage, and I put cardiac damage in between quotations. And basically, this is a very nice study from Dr. Genero Philippe in Europe. Stage 0 is where you have aortic stenosis with no cardiac, at least, involvement that you could see. Stage 1, LV damage, and described as an increase in LV mass, a tissue Doppler mitral inflow, basically diastology that is altered, and an ejection fraction that is depressed. So stage 1 is mostly left ventricular involvement. Stage 2 is left atrial that is enlarged, mitral regurgitation or atrial fibrillation. 3, you can start thinking, go into the right side of the heart, pulmonary vasculature, systolic hypertension, moderate to severe tricuspid regurgitation, and stage 4 is RV damage, moderate to severe right ventricular dysfunction. Now, we usually see this in the older days when you have quote-unquote almost burned out aortic stenosis. And patients have been either not seeking medical help, and you see them in a very, very later stages. But we know nowadays that you could have an involvement of the right side. You could have some pulmonary hypertension, particularly in the older individual, RV dysfunction, other things that would cause particularly things on the right side of the heart. So it may not necessarily be related. However, as you will see, it's prognostically important in such patients. And the prognosis is shown here. If you have stage 0, which is no cardiac involvement, the prognosis is really very good at 1 year, basically. And your prognosis is worse if you have stage 4, meaning bad aortic stenosis, ventricular dysfunction left and right, and certainly would make a situation for a worse prognosis. And I think this has also been studied in other situations, but I think it's important to keep in mind that they may not be sequential, they may not be linear. However, I think we know that the presence of other ailments in the heart, pulmonary circulation, other things that significant diastolic dysfunction certainly can impart prognosis. How about moderate aortic stenosis? We haven't talked about it. Is the prognosis, very good? Is it similar to somebody with mild aortic stenosis? Should we do anything about moderate aortic stenosis? These are some sobering data, actually, recently published in JACC, that this is patients with no aortic stenosis. This is all-cause mortality. Obviously, whenever you have all-cause mortality, many other things come to play. Mild aortic stenosis, moderate aortic stenosis, and severe aortic stenosis, where the mortality is certainly very high. Now, interestingly enough, the moderate aortic stenosis were not too much behind the severe aortic stenosis. Now, you could think of there may be other circumstances, not necessarily only related to the aortic valve, but I think it's up to us to decide and investigate whether even aortic stenosis per se in the moderate range can impact systolic or diastolic function, particularly in certain situations, and impact prognosis and survival down the line, particularly that patients are surviving longer, they have other comorbidities, and whether this is contributing to the overall situation. So a similar analysis for moderate aortic stenosis, looking at these groups of 0, 1, 2, 3, and 4 involvement, where you have the right ventricular involvement. So in a similar situation to Dr. Devereaux, Genero, and the outcomes in these patients are along the lines what you saw for severe aortic stenosis: all-cause death plus stroke and heart failure. That the group 4 is the worst, and group 0 is certainly the best. But remember also that even group 0 did not have a great survival because obviously most likely of age and other contributing factors. But irrespective, you could see this gradation of prognosis with more and more cardiac involvement, left ventricle, left atrium, pulmonary pressures, etc., etc. And last but not least, and I think this is an important one, and as you will see will be investigated, is the issue that we hassle with most of the time, is this low flow situation, heart failure with reduced ejection fraction. Does aortic stenosis, even in the moderate range, impact prognosis in such patients? And indeed it does, actually. If you take a look at this is follow-up in time, cumulative incidence of mortality of patients with reduced ejection fraction without aortic stenosis. And if you add moderate aortic stenosis to such patients, and it seems that it may be a contributing factor, certainly that needs to be investigated. Preliminary data, again, very recent in JACC, telling us that if you intervene on such patients, and this is HFrEF with moderate aortic stenosis without intervention, this is the worst prognosis. But if you intervene with an aortic valve replacement, the prognosis appears to be a little better. So we have to keep that in mind, going forward. I would like to refer you to two most recent guidelines, the 2020 ACC-AHA, but also 2 weeks ago, the ESC guidelines for valvular heart disease, which I think are very revealing. I'm not going to go through the management of aortic stenosis, but the one that usually not necessarily keeps us at night, but the no symptoms severe aortic stenosis. The decision modulators are Vmax, ejection fraction, exercise capacity, BNP, now in the guidelines, rapid progression, and other cardiac surgery. So many things are not necessarily yet addressed in the guidelines. Many of the things that I showed you regarding myocardial structure, damage, and other things, but these are some of the ongoing and planned studies that could change aortic stenosis management. Early TAVR, this is TAVR and asymptomatic severe aortic stenosis. The Evolute Expand, which will evaluate TAVR in patients with symptomatic moderate or asymptomatic severe aortic stenosis. TAVR Unload, which compares the efficacy and safety of TAVR in addition to optimal heart failure alone in patients with moderate AS, similar to the study I just quoted you there with reduced ejection fraction. And one study that is ongoing, this is the EVOLVE trial using biomarkers along the lines of CMR that we talked about, is there, whether there is mid-wall late gadolinium enhancement, yes or no, and randomized. And I think these will be very informative for us going forward in trying to optimize the management of patients with aortic stenosis. So what I wanted to do today is to go over some of the recent data regarding giving us insights into aortic stenosis. And many of it's challenging kind of certainly situation, but we have an advantage nowadays than compared to 10, 15 years ago, where we have powerful diagnostic modalities of various imaging. We have biomarkers, and I think therapeutic interventions with TAVR that could be very beneficial for us to intervene maybe a little earlier on such patients and hopefully improve prognosis. So thank you very much for your attention. I would love to hear from you, and if you have any questions, we would love to try to answer them. All right, I see a question here. Let me see here. Is it possible to get a stroke volume index in patients with low gradient severe aortic stenosis, and how we do approach these patients? And is it possible to get an ejection fraction? Obviously, patients with low gradient severe aortic stenosis, you have to keep in mind as to what the stroke volume is and what's the cause of the reduced stroke volume. I think you should get as much information regarding that and corroborate it with the ventricle itself. If the ventricle is small and the ejection fraction is normal, you know you're dealing with a lower stroke volume situation. If the ventricle is large, it doesn't, and depressed ejection fraction, it doesn't mean that it is a low stroke volume, right? Because if the ventricle is large and you have an ejection fraction of about 30% or so, stroke volume could be still normal. For aortic stenosis, which other investigations are advised, and what do you advise as gold standard for stroke volume? I think there's whichever way you can measure stroke volume, I think is fine to me. With echocardiography, you can have two different ways of measuring stroke volume, actually even more. You could have the LV outflow site. You can have the ventricle itself that we talked about. And also, we can have different other sites. If the LV outflow site is difficult, you could use the mitral or pulmonic. So there are different ways of doing it. And if you have 3D with good optimization and contrast, you can get a good volumetric approach. That's one. Two, if you're concerned about any of these with echocardiography, CMR is a very powerful non-invasive methodology for you to do that. So with CMR, I think it is the gold standard nowadays for volumes, ejection fraction, as well as stroke volume measurements. Keeping in mind if there are regurgitant lesions, and otherwise you have to think about flow going through the aortic valve. So you have to correct for mitral regurgitation if there is, and so many other things. I would not discount still using invasive measurements in case you don't have CMR, in case you have an echocardiogram that is difficult. You know, these are, you should use whatever is available, whatever give you the diagnostic modality for you to be able to manage such patients. All right, I think I don't see any further questions. Pleasure having you, and look forward to seeing you again in our grand rounds throughout the year.